Clinical lecturer, certified at Faculty of Medicine, Yashi University, Jakarta since 2019. He is also working as a child and adolescent psychiatrist at Klender Islamic Mental Hospital, Jakarta, and psychiatrist at Antam Medica Hospital, Jakarta. He is a member of Indonesian Medical Association as well as a member of Indonesian Psychiatric Association, Jakarta. Welcome, sir. Now I will introduce. Welcome, sir.
Yeah, thank you.
And now I'll introduce our panel of experts. We have with us today Professor Dr. M.S.I. Mollik, ex-chairman, Department of Psychiatry, Bangabandhu Sheikh Mujib Medical University. Professor Dr. A.A. Mamun Hussain, sir, ex-chairman, Department of Psychiatry, Rajshahi Medical College and Hospital. Brigadier General Professor Dr. Muhammad Adijul Islam, ex-professor and advisor, Department of Psychiatry, Armed Forces Medical College. We have with us Professor Dr. Salahuddin Kaisar Biplab, Professor, Department of Psychiatry, Bangabandhu Sheikh Mujib Medical University, and Dr. Helaluddin Ahmed, Associate Professor, Department of Psychiatry, National Institute of Mental Hospital. And our vote of thanks, Mr. Ghulam Haider, Deputy General Manager, SK Pharmaceuticals Limited. Welcome, sir. I would like to thank you all for joining us today in this special webinar arranged on the occasion of International Suicide Prevention Day. As we all know that every year, the 10th of September is being celebrated as International Suicide Prevention Day across the world since 2003. Our this year's theme is creating hope through action, and our this program's title is School-Based Mental Health Program on Teen Suicide Prevention, Risk Factors and Psychological Issues. So now I would like to request Dr. Isha sir to deliver your presentation.
Okay, thank you for inviting me in this nice event, international webinar from Bangladesh Psychiatric Association. This is for the first time I collaborating and join with the South Asian region. Thank you. Please, I want to share the presentation. The host disabled participant, please open the host. Please help to open share. Okay. Okay, thank you. Okay. For the first time, I want to read the title, School-Based Mental Health Program on Teen Suicide Prevention, Risk Factor and Psychological Issue. The experience from Indonesia. This is my curriculum vitae. Next. Okay, for the introduction. WHO Global Estimate 2070 data show that the highest global suicide deaths are at the age of 20, especially in low and middle income countries. The burden of morbidity and mortality from non-communicable disease has increased worldwide and is growing rapidly in low and middle income countries. Meanwhile, the burden of infectious disease has decreased. This certainly requires attention from the mental health sector to develop a prevention program, especially suicide and self-harm in the community, targeting youth group through school-based mental health program. Why we start in school? The reason is highest likelihood of exposure to a prevention program for adolescents. Affect large community connected to the school. Teachers are inadequately trained on issue regarding adolescent suicide. So we must doing empowerment of teacher and pupil as a gatekeeper, also professional on mental health for doing activity like Q&A, persuade, referral, screening, and awareness for mental health. The project in Indonesia, we start mental health based on a school, aim to get the data about incident case of suicide attempt, suicide ideation, self-harm behavior, bullying, including having a suicidal plan. Also, we want to getting the data about incident and prevalence of mild, moderate, and severe depression. This is the time of World Suicide Prevention Day, in 20. It at now creating hope through action, September 10, for International Association for Suicide Prevention. So we celebrate this day for World Suicide Prevention Day. Okay, focus on child and adolescent mental health in Indonesia. Suicide among child and adolescent is a growing phenomenon, but is often neglected. Adolescent suicide has been established as a serious health problem worldwide. Because I stay in urban city, Jakarta, the capital city in Indonesia, urban life cause of increasing psychological disorder in children and adolescents. Anything increased case of self-harm in children and adolescents during the COVID-19 pandemic at current now. Emotional disorder also show the largest observed increase in frequency in 2020 from 58 to 66%. So we want to explain about suicide fact in teens is so important. Why? Because the age of suicide of children and adolescents range for 10 and 24 years. There are twice as many suicide in boy as in a girl. Study case report show that age of suicide 10 to 14 years, 20%, mostly in girl, and 15 and 90 years in mostly boy, 65%. The most common mental disorder problem related to suicide in adolescent is depression, to 20.8%. Okay, and suicide is one of the three leading cause of death in individual age 15 and 35 years. Suicide attempts are the most common reason for seeking psychiatric care in the middle of adolescent. This is the table about mental disorder related to teens suicide cases. For the first level is a mood disorder, like as depression, 42.1%. And second, substance use disorder, disruptive behavior disorder, personality trait, adjustment disorder, anxiety disorder or somatoform, and the last is schizophrenia and psychotic disorder. If we share about suicide, we must know the prediction factor and precipitation factor. For the first is family, such as toxic parent, mostly loss of one of both parent in childhood, critical age, as a result of divorce and separation or death for lovely parent. The presence of parent with mental disorder and history of parent who died by suicide is important. Another stressful parent-child relationship, like parent high expectation of their child school achievement. Another is loss of a primary caregiver, disrupt the structure and organization of the child in the neighborhood due to feeling of insecurity. And another parenting style overprotective, neglected. I'm sorry, I want to check the battery. Sorry. Okay. Yeah. Then the parenting style is very important, like as overprotective and neglected. This is the pathway suicide behavior on teens. We have the two pathway. For the first is the primary pathway, like as vulnerability for interpersonal distress and internalizing disorder. The secondary as independent pathway is externalizing disorder, like as impulsive self to cause harm and acting out vulnerability. Another non-suicidal self-injury. After that pathway, we have suicide ideation from from adolescent. And the next the pathway can be to spectrum suicide, such as suicide trait, suicide gesture, deliberate self-harm. And the next suicide attempt, for the next again serious suicide attempt, and the last is interrupted suicide from after 2017. Another factor like psychosocial is very highlight, like mental disorder. 2 per 3 of teen suicide suffer from mental disorder. In Indonesia, the prevalence of depression in population age 15 years and over is 60.1%. This is the main predictor on adolescent to doing action suicide. Another factor is history of previous suicide attempt, 22%, and reported in girl 33%. In late adolescent group, 30% who had suicidal ideation. Another psychosocial is a stressful life event. Psychosocial on youth have a significant effect on suicidal ideation from the research by me, 2018. Another is family history with psychopathology, and with the social environment, decently populated environment. We must have known about a precipitating factor for suicide in child and adolescent, mostly adolescent. In Indonesia, is mass media reporting on violence, suicide, can be imitating self-harm as a last resort. Psychosocial stressor like in school, academic failure at school, frustration in love, bullying in school from teacher and or friend, and peer rejection. In stress pandemic COVID-19, we have many reason for adolescent have depression and self-harm, like school closure, online class, and current is a government plan to start opening face-to-face learning program in school. Maybe that make anxiety and depressed from the student for the first time to go back to school. Another is conflict with parents, like as family dysfunctional. For the internal of teenagers character who tend to be emotional. This is will be make the inability to tolerate failure. And another from my report, increases case of youth self-harm behavior as a cause of hospitalization in the psychiatric ward for child and adolescent in my hospital, my mental hospital on COVID-19 pandemic, Dr. Suharto Herjan Mental Hospital Jakarta, Indonesia. After February to this current now, the depression case is increased in my psychiatric child and adolescent ward. This is the I want to report about suicide research in Indonesia. We have WHO estimate that the incidence of suicide in Indonesia is 4.3% per 2000 population. To 2000 population. WHO. The study from the Indonesian Ministry of Health in 2040 conducted an extrapolation study show that the suicide rate in Indonesia was 1.77 per 100 population. 1,000 population from Minister of Health 2000.
100,000.
The data based on the sample registration system in 2016 in Indonesia show the prevalence of suicide in Indonesia is 1 people per day, with estimation every 4.8 hours suicide occur in Indonesia. According from the study on youth population of health of the Republic in Indonesia in 2030, the prevalence of suicide ideation was 0.8% in boy and 0.6% in a girl. And this is interesting. The study show that suicidal ideation is more common in urban area than in rural area. The study from our colleague 2019 show that 5% often in Jakarta, Indonesia have suicide ideation. And students who were detected at risk of suicide had a 5.39 times greater risk of having suicidal ideation than students who were not detected at risk of suicide. For the next, I will show you the biological marker and stressor. That is must be attention for detection in child and adolescent related to suicidal. For the first, decreased level of tryptophan in the blood, a marker to identify children at risk of suicide. Number two, serotonin-related anxiety and aggression stressor precipitate depression. Number three, the association of low serum cholesterol level with suicide in a depression patient. And in the COVID-19 pandemic, cytokine depression hypothesis, this is very interesting in Indonesia. We call is badai sitokin ya in bahasa because cytokine as pro-inflammatory and anti-inflammatory to immune system for the human. And another issue, highest rating psychosocial stressors like are more likely to rank lower than expected. A friend said betting, a family member die, a breakup with a girl or boyfriend, and a serious quarrel with a friend is the reason for stress in adolescent Indonesia. Another non-suicidal self-harm often co-occurrent with suicidal behavior in Indonesia. And another, communication difficulty like self-disclosure, loneliness, avoidance, that make the increase the suicide for individual. So for the project in Indonesia related to school-based mental health, we want to empowerment of teacher, pupil, and parents. Like the program for the first screening tool for risk factor on adolescent suicidal, training for teacher and cadre on early detection mental health problem, to recognize sign of emotional and behavioral problem in child and adolescent student. Another, we doing psychoeducation on awareness on teen suicide prevention, such as counseling and continuing education about contemporary issue of child and adolescent mental health. For example, game and internet addiction highly in Indonesia after COVID-19 pandemic, and healthy and sexual risk behavior. Another, we doing screening on child and adolescent mental health at school, like regular school, inclusion school, or a special school. And we doing a poster competition on public mental health awareness for the student participant. Another, we doing assessment and promotion on mental health problem at teenager in National Health Jamboree 2019. And another, training home care on awareness mental health, like cooling down with a simple relaxation exercise, calming self-talk, stop negative and overthinking, uh, with the principle acts without thinking, and attention diversion. For the second, we are doing empowerment of professional for aim doing screening and teach additional skill. The program such as suicide toolkit for patient in emergency room, like suicide scale, socialization about teen risk factor for suicide in bahasa Indonesian language, partnered with NGO related to suicide prevention in national region. We have into the light the community for suicidal prevention. We doing in community mental health. We doing a joint seminar with a regional clinic or regular school education for child health on poor urban area. Another, we doing workshop about child trauma and child play activity for social worker and teacher on children nursing service and handicap school. For the last, we doing training for general about child and adolescent psychiatric emergency, such as interview skill, role play, and video stimulation. This is the picture when training and physical in community related to teacher, teacher. And this school-based mental health program, we collaborate with the teacher in school for early detection on mental health problem and sharing about again to stigma child and adolescent youth mental health. We doing a very interesting week because we have 1,000 island near with Java Island. So we reach another island, the small another island, to doing inter-island community mental health service model. This is our project when doing in a big city in Thousand Island. And another, we doing a family mental health promotion about education and health promotion related to risk behavior problem. When we doing the program for in school-based mental health, we are doing for the main program is early detection on youth mental health. We doing many instruments and assessment tool such as adolescent suicide risk assessment, short form for community only, youth risk behavior surveillance system YRBSS, using 5-item question related to mood depression and suicidal ID. And we doing teach the teacher and social worker to using a strength and difficulty questionnaire SDQ in bahasa, in Indonesian version. And we teach the professional mental health professional to using patient health questionnaire PHQ-9 Indonesian version. Another, we doing assessment with youth suicide screening toolkit Indonesian questionnaire modification. And our government, Ministry of Health in Indonesia, have a guideline for referral pathway on suicide and self-harm assessment to level and next the level. Gitu. In another, we doing socialization about in-depth interview for suicidal ID in clinical setting for GP, general practitioner, after referral, and assessment after suicide attempt. This is a clinical setting for health practitioner. For the current after COVID-19, we expand to telemental health. Yes, we doing digital mental health in our mental hospital to make outreach program for the community mental health on Indonesia student and child and adolescent population, digital mental health, use of technology, accessible digital platform or application for mood problem and psychological problem in adolescent, based on of the sophisticated of smartphone and mobile phone and internet access of service with name online therapy. Ministry of Health Republic of Indonesia launching the Sehatpedia application for online consultation session with doctor, and another doing artificial intelligence AI, a guide in digital application in helping the activity of teenagers who experience health problem and reminder to take medication or healthy living behavior for activity daily living. Dr. Suharto Herjen Mental Hospital, our work have launching application developed that make it easy to access urban mental health service, call name the Sejiwa, and with consultation in outpatient, we doing telemedicine service for consultation on mental health program during pandemic COVID-19. This is the application from our Ministry of Health, the Sehatpedia. We can check and touch screen for making appointment for consultation and take the communication. And this is the digital application. At now, digital mental health can be related to artificial intelligence to help the detection of mental health. This is the risk factor on adolescent student from this PhD study in Indonesia by our colleague. Many risk factor on student adolescent. For the first is abstract thinking that give rise to risk-taker behavior. The second, genetic transmission that can lead to aggressive and impulsive trait, have a history of mental disorder, unsupportive social environment, abuse of internet access, and excessive internet use. This risk highly in middle adolescent phase. A similar study was also conducted by the Global School-Based Student Health Service survey by Ministry of Health of Republic of Indonesia with sample of youth. That research is showing 5.2% of adolescents has suicidal ideation, 5.5% had planned to commit suicide, and 3.9% had make a suicide attempt. How to action? So we must be pay attention about this project in school, yeah. Improving the competency of general practitioner in primary care to caring about physical and psychological institution through collaboration with a teacher in school, crisis intervention after stress mitigation on child and adolescent with when doing early detection and mental health assessment on school, post pension. This is very interesting. The term used to describe crisis intervention for family and relative that are carried after a suicide for individual. Regulation must be attention to limit the coverage of suicide on television or the theme of soap opera in prime time that encourage suicide behavior and self-harm on child and adolescent. And another, facilitating a creative program between parent and child through activity in the public space integrated child-friendly area and school environment like sport, play, and art therapy room. The Indonesian program, we have training for peer counselor for increased counseling skill in counselor and student, yeah, for help the another student. School-based mental health program in inter-island community mental health service model in 1,000 island parts is from the Jakarta province of Indonesia. Another, we have program integration in first level health service, especially primary healthcare. And we have hotline service for suicide counseling was less active in 2010. Into the Light Indonesia, a community that focus as a center for advocacy, study, and education on suicide prevention and mental health in Indonesia. From the left, building coordination with social service in the region to change the community stigma about mental disorder. And the conclusion, suicide and self-harm behavior are mental health problem that need attention in youth population. The problem of suicide need to be handled in a multidisciplinary sector based on biopsychosocial and spiritual concept. Prevention of suicide in adolescents can be developed by collaborating across sector to raise awareness and reduce stigma about mental disorder on youth. The program can be started from the school level through empowerment of the role of teacher, student, parent, and related health professional with digital technology. This is my reference from the left. Don't ignore the sign. Help your friend. Don't wait till it's too late. Thank you. This is my email and my Instagram. Thank you very much. Thank you very much, and I'm happy to share this presentation. Okay, I back to the moderator. Thank you very much.
Thank you.
That was an excellent presentation delivered by Dr. Isha Noor. I would like to thank you, sir, for such a nice presentation on the burning issue of child mental health as well as child suicide. Dear audience, you can ask any question regarding today's topic in our comment section. We will try to answer your question. At this moment, we will start our panel discussion session. I would like to request Dr. Helaluddin Ahmed sir to make a couple of comments regarding today's presentation.
Thank you, sir, and thank you. I first congratulate my friend, Dr. Isa. You are my very old friend, and we met in the Japan, Jaipur, and many occasions in the world. And also, I give my congratulate to our honorable chairperson of this session, Professor Dr. Wajalan Choudhury, and all of my teachers are the panelists. They are all of my teachers. So it is my great privilege to say a few words in front of you. And I just want to share not mention about the very time demanding topics and the findings showed by Dr. Isa, and the cultural variations from the Indonesia and Bangladesh not very far. So I think all the data and all the things are very resemble with our Bangladesh. That's are more similar within our country also. And we have done also our own study in the suicidal risk behavior among the adolescent and youth. We have to disseminate tomorrow into a seminar. And there we found the adolescent and the youth that have the 5% have the suicidal behavior. Actually, they have the planning, they have the thinking about suicide, and 1.5% have the suicidal attempt also among them. So there are some socio-ecological risk factors we found regarding they are not manage their emotions, and some relationship status with the friends and the families. And these are the very similar within the Southeast Asian region also. And there are some Bangladesh, Indonesia in the same pace in the suicide prevention and in the context of the suicidal rapes. And I am not talking too much regarding these issues. Our learned professors will be here. And I give again thanks to give me the opportunity to say a few words in front of you. Thank you, sir.
Thank you, Dr. Hilal.
Thank you.
Thank you, sir. Now I would like to request Professor Dr. Salahuddin Kaisa Biplop, sir, to comment briefly regarding the presentation.
Thank you very much, Liuza and Dr. Isa. He is also my friend from last 10 years. I think that was in 2011 we first met in Melbourne. So I am giving a special thanks from Bangladesh, from Moner Khabor, and from all of the community of mental health related person from Bangladesh. And I think the picture you have shown and the design you have shown regarding the mental health and the suicide prevention program in the school in Indonesia, I don't know how it is possible, but a bit difficult because of lack of in Bangladesh, because of lack of manpower. I don't know about the total amount of manpower in Indonesia in the school and the community based or in the psychiatric. Is there sufficient manpower specialist is present in Indonesia or not? But I think it's a good model, and this is very interesting also. Participating from the parents, from the community and school teachers and other people. So if it is totally is, I will say is applicable, and that will give you a result within very short time. So, and another person is that we from Moner Khabor, we try to maintain this international webinar every month so that we can exchange our knowledge. And our student, our experts and mental health related people, those who are working in the Bangladesh, and I think it would be possible to compare where we are and exchange the knowledge about latest updates, latest scientific research works. So with the support from all the experts, all the panelists, and all other my teachers, my colleagues, we will try to maintain this international webinar every month, if possible, with the support of you. And last, my special thanks to Ghulam Haidar and his team and his organization for giving the opportunity to organize this sort of program, international program, and deliver this sort of important topic and presentation webinar with the to our students, to our people of Bangladesh, and also our mental health experts of Bangladesh. So thanks again for participating and giving us the opportunity to share the knowledge of Indonesia and Bangladesh. Thank you, sir.
Liza, एक minute. सुनते बच्चों okay, Liza?
जी sir.
If possible, rather you can invite Dr. Professor Mollik. Possibly he is in hurry.
Yes, sir. Okay, thank you, sir. Now I will request Professor M.S.I. Mollik, sir, to make some remarks regarding to this presentation.
Thank you so much indeed, and I really so happy to present here with this topic, suicidal prevention in the school-based program. And before starting my talk, I would like to congratulate Dr. Isha for very, very, very enriched content of your presentation, and I agree with Dr. Hilal that more or less we have the similar scenario, but really I am surprised that you have actually advanced in a lot of areas, particularly in this field. Let me give some important point. I am not willing to clarify everything because every year we usually talk about this topic in Suicide Prevention Week, and certainly at this time, the suicide and childhood depression and suicide and self-harm is the most important burning issue and challenges at this point, and suddenly the burden will increase in future. And considering this one, almost all international and regional bodies declare that the most challenging in child psychiatry, child and adolescent psychiatry, is the depression and suicide. Second important is that in most of the developed country and a significant number of developing countries, already they have adopted the National Suicide Prevention Program. That is so important to combat this problem. And as a part of this National Suicide Program, the school-based suicide prevention strategy is actually most important, almost everywhere. And considering the problem and its extensive etiology and psychopathology, we can assume that multi-professional and multi-agency involvement is essential to prevent this one, because this burden is not actually, it is not possible for a child and adolescent psychiatrist or child and mental professional to carry this huge burden. And if we can develop the local resource-based feasible suicide prevention strategy, that actually possible in my point of view, and you will find that there are a lot of potential manpower. I repeat the word, the potential manpower. Almost all school teachers can be the manpower of the prevention, this prevention strategy. And both parent, either parent and family, as Isha also mentioned about this one, this involvement of the family and teachers and the students is also essential. With this point of view, we can let us think in a small thing that in suicide, the person usually lost their connectiveness. About the school, we can say that it is the educational institution, at the same time it is social institution. And unfortunately, what we are actually observing, this is increasingly confined and centralized with the educational activities, purely educational, that actually can help the student to achieve the good mark, good career, good grade. However, the social component of the school is gradually ignoring. So if a school does not have any in playground, and some school have playground, but they have no program in the playground, and their teachers do not allow to play them in the school period. So how you can develop the connectiveness from the school? So here the educational agency and social agency involvement is essential, I think. And we have a huge potential manpower that actually can work with this one. Considering the basic package of suicide prevention program in school, it has actually important component is only three. Number one is that there should have the activities that can promote the connectiveness. And there should have the second component is crucial, that they identifying the risk population. And third one is that the interconnecting activities of the school to prevent the, as well as if it has happened, how to combat this one.
Yeah.
So with this
And
point
right.
of view,
Yeah.
I think it is the time for Bangladesh Association of Psychiatrists and Bangladesh Child and Adolescent Mental Health, they should take an initiative about the school-based prevention strategy. And we can take two schools, one from urban, one from rural initially, and we can develop a package of prevention strategy. And with the school authority and with the parents and with the help of other resources, we can start a piloting of a prevention strategy that could be possible in our country. So we should start as earlier as possible. And Hilal and other professional we have, they have a huge potentiality and good connection with the government and DG Health, and they can create a proposal about the school mental health piloting, suicide prevention piloting program, and they can also, I think, they can able to receive the fund also, and the multi-agency involvement could be possible. At the same time, we have to work for the adopting national suicide prevention program and school-based suicide prevention strategy. And this should be initiated, groundwork should be initiated by BAP and BECAM. I think it is the responsibility of them, because they are the advocacy group. They have this highly potential ability to advise the government to take this program. So we can start with a small piloting, and we can go for a roadmap for adopting national suicide prevention program as well as school health suicide prevention program. If we can start this one, I think we can say that we have done something, rather than saying a lot of talks year after year. This is a time actually we have to go for some action program. So with this view, I would like to stop here. Again, I would like to congratulate the Isha and others. They can contribute a huge with these issues. And again, I would like to repeat that this is really time-oriented program to combat this program at this point and in future. Thank you so much.
Thank you, Rob.
Thank you, Maulik sir, for your expert opinion. I cannot see any question in our comment section as of yet. Dear audience, if you have any question regarding today's presentation, you can drop your question in our comment section. We will try to answer your question. Now I will request Professor Dr. Mamun Hussain sir to make some remarks regarding the presentation.
Thank you very much for your kind introduction. Well, this was a very unprecedented experience to listen to Dr. Isa Muntazam Noor from Indonesia. To Hilal, he was very acquainted, I could gaze. The last speaker, Professor Mollik sir, he made a very vital comments relating some of the strategic aspects. Hopefully, Dr. Isa will bear me out. Of course, we have some common issues regarding the Southeast Asian problems, but I do believe that possibly he will bear me out that Indonesia, in fact, is a large archipelago, so many islands, so many connected. And this is a country which is multicultural, multilingual, multi-ethnic. So very difficult to make connectivity. The word, the connectivity, Professor Mollik sir was telling, because I could gauge that about 700 languages exist, more than 1300 to prevailing. So very difficult to maintain connectivity. So to me, Indonesia actually, how I could remember by one of one master novelist, Robonto Anantatuer. Yeah, you know that. Yeah, you're the master novelist. I could go through his book, and so far I could remember in Indonesia in 2012. Actually, there was Bali bombing. Possibly you remember, and I remember that 2004 there is a high Indian Ocean earthquake, tsunami, and it cost about 1,330,000 people's killing. So this actually I remember. And you know, this is the country, of course, a Southeast Asian country, but there's a huge colonial experience, especially mostly from the Dutch peoples, and possibly they got independent from the Dutch peoples, and they have rich cultural heritage. The blending from Indian subcontinent, mainland China, Middle East, and Europe. And you've been knowing that they have some puppet show, wine, and that reflects the Ramayana and the Mahabharata. So many ways they are much connected. And one thing just reported from BBC that the high recession in Indonesia is taking place in the last 22 years, and which is causing about 3.5 million people, they'll be losing job. So among these huge turmoils, I think Indonesian mental health professionals under the leadership, if I could gauge Dr. Isa, they're doing a very wonderful job. And I take the opportunity to extend my heartfelt felicitations. I remember that, you know, that Indonesia is a transit country, and there is also problems of refugee. And refugees are more vulnerable to commit suicide because people from Afghanistan, Somalia, Myanmar, Iraq, Sudan, they're just crossing the transit country. So these are some points which I could gauge. In spite of all these things, so far I could gauge the presentation. I think it was very updated, full of insights. I think there's many learning points for our peoples. Hopefully we'll be formulating, because every program needs to be culturally sensitive, which I do believe. What I could gauge, Dr. Noor can answer that. In Indonesian ministry, I could find that you launched some hotline. I was going through some data. It was projected that 2010, 161 people seeked advices, counseling. In 2012, 347. But suddenly in 2014, the seeking advice suddenly dropped to 46 people. Why? Is there any problems of efficacy of maintaining hotline? Because often we talk about the hotline. I think you can make some big comment. But some very representative works are taking place. If I remember, in Bali, there is about 11 groups of NGOs. They are doing love inside suicidal awareness. And you talked about some of the apps, I think artificial intelligence. And if I remember, in YouTube channel, I found one presentation, just a joint venture of the UNICEF and Center for Indonesian Medical Student Activities, They are having some session bi-weekly possibly, and they are talking about it. In Bengali, I'll be talking. You have one belief, Pulang Gantung. I think I will make some comment in Bengali if you do allow. আমি আমাদের বাংলা ভাষাভাষী জনপদের জন্য বলি যে ওদের একটা লোকবিশ্বাস আছে যে আমাদের ধূমকেতুর মতো একটা আলো, which is a very reddish yellow light with blue flash tail, এটা আকাশ থেকে উড়ে যায়, উড়ে যে বাড়ির ওপরে পড়ে, বাড়ির কাছাকাছি পড়ে, ধারণা করা হয় that man is going to commit suicide. এটা একটা লোকবিশ্বাস আছে। আমি জানি না আজকে এটা খুব পার্টিনেন্ট কিনা, বাট দিস থিংস অ্যাকচুয়ালি কাম টু মাই মাইন্ড। আমার কাছে যেটা মনে হয় যে আমরা যখন সুইসাইডাল টিম নিয়ে কথা বলি, কতগুলো মিথ কাজ করে। আমরা অনেক সময় মনে করি যে টিনেজার যদি একবার ডিসাইড করে তাহলে কখনোই তাকে বিরত রাখা যায় না। আমার মনে হয় সব সময় কথা ঠিক না। আমরা অনেক সময় মনে করি যে তাকে কি জিজ্ঞাসা করব তার মৃত্যু ইচ্ছা আছে কিনা, আত্মহনন, স্বেচ্ছা মৃত্যুর ইচ্ছা আছে কিনা। অনেকে আমরা মনে করি এই কথার মধ্যেই যে তাকে বোধহয় সুইসাইডাল আইডিয়াদের দিকে প্ররোচিত করছি কিনা। আমার মনে দিস ইজ অলসো মি। এবং আমরা অনেক সময় মনে করি যেভাবে যে আচরণ সে করছে, it is just mere attention seeking behavior. But I don't think these are all math, these are all myths, and this should be addressed আমরা যখন পেশেন্টকে করি। এবং রিসার্চাররা বলছেন যে আমরা যখন এরকম একটা পেশেন্টকে দেখি, তাৎক্ষণিকভাবে তাকে হিউমিলিয়েট না করা, প্যাসিভ না থাকা, ইগনোর না করা, এবং in the very moment we should not go for debate যে জীবন এবং মৃত্যুর মানে কি, এই বিষয়গুলো বলা নিষেধ করা হয়। এবং যারা আরো সুইসাইডে, টিনেজার সুইসাইডে স্পেসিফিকলি কাজ করছেন, তারা বলছেন যে ফলস রিঅ্যাসুরেন্স যেন আমরা না দিই, স্পেশালি প্ল্যাটিটিউড। প্ল্যাটিটিউড শব্দটি মানে হচ্ছে মামুলি মন্তব্য করা, চট করে হ্যাস্টি একটা কমেন্ট করা। এবং আমরা সবসময় জানি যে সাইকিয়াট্রিস্টরা, আমি ব্যক্তিগতভাবে আমার সেন্স অফ মোরালিটি, সেন্স অফ জাজমেন্টকে ইম্পোজ করতে পারি না উইথ দ্যাট পার্টিকুলার জেন্টলম্যান। তো এটা আমার কাছে এই বিষয়গুলো মনে হচ্ছে যে এটা হয়তো বলার বিষয় হচ্ছে। And Dr. Noor, he talks about many of the interventions I could read. You talks about the quotient or sphere reflex, actually reflects the concepts of the gatekeepers. Possibly our associations and our senior colleagues, they are thinking to just making some comments, and they will be taking the issues, how to train the gatekeepers so that they can identify the warning signs. And also there is a curriculum-based intervention, science of suicide, good behavior game, many things actually practiced in the Europe, family checkup, family bereavement program, and there is very brief intervention. Even the people are saying that when you identify somebody as a suicide, even you can send some postcard. This postcard can help and can make the right connectivity. And we can find that many of the, you talked about the artificial intelligence and some of the smartphone apps. If I remember, some apps are practicing in Europe, like the web festivity, iBubbly, Reframe IT. I think in that aspect, Indonesian people, you people are doing a wonderful job. And this is a wonderful learning session for us. And once again, I take the opportunity and to welcome you, and hopefully we'll be in contact. And thank you very much for your kind attention. Thank you very much.
Thank you, Prof. Thank you very much.
Thank you, Mamu sir, for your expert opinion. Now I will request Professor Mohammad Ajizul Islam sir to say something about the presentation.
Thank you. Respected chairperson of the session, Professor Wazir Alam Chaudhary, President, Bangladesh Association of Psychiatrists. Respected panelists, my teacher, Professor M.S.A. Maulik, and other panelists. It's a pleasure for me to be with you all here in this evening.
Yeah.
And first of all, I like to congratulate Dr. Isa. It's a wonderful presentation as I feel. And I appreciate your works in the field. What I feel and I saw in your presentation that you have been tremendously working in the field to prevent the suicide among the teenagers. The school-based mental program on teen suicide prevention is a very encouraging, appreciating endeavor that you are doing in your country. And I have been wondering, and I have been enjoying your presentation, the way you were working in the community, in the school, using the multi-sectoral, multidisciplinary forces. It's very nice to see. It's very encouraging for us also. And I again want to thank you that in the young age that you have, you are stepping in so many activities. You are working in so many good field to work. And that is wonderful. Thank you very much, Issa. So the suicide, what I say, a blooming flower drops, a life, a candle, just it goes off. So a life is dropped from the road. It's a very loss for everyone, a loss for the individual, for the family, for the community, for the society. So a suicide, what the statistics said, you have shown many statistics that, as I know, in 40 seconds, one individual died in any of the part of the world, in every 40 seconds. That is, in last 1 hour, many people has given their life. So it is very crucial and very crucial for the teenagers. Very crucial for the, as you have shown, the third leading cause in the age group 15 to 25. So the main important work that you are doing is very good. What we need to do in our country also, we have to address this issue with the stakeholders, with the students. That is, you said pupil. We used to use the word pupil in our very while we were in class 2, 3, but we don't use now pupil. We use students. So we have to involve the students who are the key and the focus of your attention, focus of us in the field, in the prevention of the suicide among the teenagers. So the main focus is this teenagers group, the school or in the college. The second, the family, the teacher, they are the other important person in the field, because they reside beside those teenagers. They see, they observe the emotions. They see, they can count, they can demonstrate the vulnerability of those people, of those students. So it is very important to inculcate, to include all those people, all those stakeholders in the community, in the group, to work against what we need to work. And then the stakeholders, that is the psychiatrist or psychologist or the social workers, those who work in the field, they should be working in the field. So a multidisciplinary, multifaceted approach is required to prevent suicide. So creating hope through action. So we need to create hope to the people, to the students, to the pupils, that you have a hope. You have a bright future in front of you. You have a good goal in front of you. You should have a good life in front of you. There is many things to enjoy, many things to achieve, many things to get. So it is very important to create all those activities. So you have to, or we have to show the hope in front of them. So despair will go out, hopelessness will go out. We'll just throw all this hopelessness, helplessness, frustration, and create the hope to our people, to the students, to the people. So this is very important. So these activities, as you have been working in Indonesia in the field level with the collaboration of the government, with the collaboration of the Ministry of Health. So we also need here some activities like that. We have to focus all those issues. We have to focus all those stakeholders. Then we have to formulate some plans, formulate some program to prevent the suicide in these teenagers. As I have been telling, these people, these students are the future of the family, future of the country. So you have to give the hope to them to build a good nation. That's what I feel and I say. I again want to thank the Moner Khabar for arranging such a nice program in collaboration with the friend from the Indonesia. Probably we will see you in future again. And I also want to thank SCAF for their kind help in organizing this program here. And I want to also express my gratitude to the president of this session and the Professor Mamun Rahman, Professor Salahuddin Kausar Biplov, the chairman of the Moner Khabar, Trebi, Professor Dr. Helaluddin Ahmed, and my teacher, Professor M.S.I. Mollik. Wish you all the best. We will be working together in the days to come, and probably we can also keep some of the footprint in the field to work to prevent the suicide in the days in Bangladesh also. Thank you very much once again.
Thank you, Ajitul Islam sir, for your encouraging remarks. Now I would like to invite our vote of thanks, Mr. Ghulam Haidar, Deputy General Manager, SK Pharmaceuticals, to say something regarding our today's program.
Assalamu alaikum and very good evening. Honorable Chairperson sir, respected speakers and panel of experts, it's my great pleasure to be a part of today's webinar. A special thanks to Dr. Isa Noor for his wonderful presentation. Moner Khabar TV কে অনেক ধন্যবাদ আজকের এই প্রোগ্রামটি অর্গানাইজ করার জন্য। মেন্টাল হেলথ বাংলাদেশে মানুষের এখন সচেতনতার অনেক অভাব আমরা জানি। আজকের টপিক যেটা ছিল বিশেষ করে টিনেজদের এই প্রবলেমটা আরো অনেক বেশি। তো আমাদের আজকের ডিসকাশনের মাধ্যমে আমাদের দেশের যে সিনিয়র ডক্টররা এখানে আছেন তারা ডেফিনেটলি এই বিষয়টা নিয়ে অনেক কাজ করতেছে। আমরা এসকেপ আপনাদের সাথে সবসময় ছিলাম এবং বাংলাদেশের হেলথ সেক্টরে আমরা ভালো প্রোডাক্ট শুধু সাপ্লাই দিচ্ছি না, আমরা ম্যানুফ্যাকচারিং ছাড়াও এই ধরনের ওয়েবিনারে সবসময় সাথে থাকতে চাই। যে কোনো সময়ে আপনারা ডাকলে আমরা সাথে থাকব। আজকের এই প্রোগ্রামের ব্র্যান্ড পার্টনার রিলাইফের পক্ষ থেকে সবাইকে আবারও ধন্যবাদ জানিয়ে আমার বক্তব্য শেষ করছি। থ্যাংক ইউ।
Thank you. Now I will request our chairperson, Professor Dr. Mohammad Wajul Alam Chaudhary sir, to say something regarding our today's presentation.
Sir, sorry sir, another point I missed just half a minute. I also want to thank Dr. Mubashshara. You had been nicely presenting and anchoring the program. I missed it. I'm sorry for it. You had been wonderful in the anchoring the program. Thank you.
Thank you, sir.
Sir, unmute করেন স্যার, unmute করেন।
এখন শোনা যাচ্ছে?
জি স্যার, জি স্যার।
Okay. So really very glad to be here with you all, like Dr. Isha Multazam Noor from Indonesia. At first, I would like to say that it's a really very wonderful presentation from Dr. Noor. So your deliberation is really very full of information, policies, intervention, activities, hope, prospects, and promises. Really, we are very inspired. At the same time, the input very important and very worth listening input given by our panelists. So I hope this will be very soon you will be able to implement this program in your country. and the inspiration and the ideas actually you have shared from your presentation. I hope our experts in this session today they have given their valuable speech. They'll also be inspired and help us to implement a wonderful program, wonderful policies just to prevent the childhood and adolescent suicide in your country as well as Bangladesh. So it's very, already we are late, so I don't want to extend my speech. Rather, I would like to congratulate you once again. I would like to offer my heartiest thanks to Dr. Lija, our learned panelist, and Mr. Ghulam Haider of SKN8 and to SKN from Mr. Ghulam Haider, and also to Munir Khabur for their wonderful participation and inviting us all to share with Dr. Noor. So thank you once again and a very, very good night. Thank you.
Thank you, Wajul Alam Chaudhary, sir, for your concluding remarks. We are almost at the end of our today's webinar, organized by SK Pharmaceuticals on the occasion of International Suicide Prevention Day 2021. I would like to convey my gratitude to SK Pharmaceuticals for arranging such an excellent program. I believe that this kind of program will help building public awareness regarding mental health and suicide as well. I also want to thank our panel of experts, our chairperson today, and special thanks to Dr. Isha Noor for connecting us from Indonesia. Thank you all once again for joining with us today. Stay safe and healthy. Have a very good night. Assalamu alaikum.
লিজা এক মিনিট হ্যাঁ
Yes, sir.
হ্যালো
Yes,
আমি
sir.
আমি বিপ্লবকে বিশেষ ধন্যবাদ জানাতে চাচ্ছি যে নূরকে ও জোগাড় করেছে আমাদের জন্য থ্যাংক ইউ বিপ্লব
জোগাড়
জোগাড় তো বটে ভাই তুমি বহু কষ্ট করে ওকে জোগাড় করেছো থ্যাংক ইউ বিপ্লব থ্যাংক ইউ
Maybe taking the session picture, taking the picture together.
থ্যাংক ইউ
Okay.
oh you want to take picture আচ্ছা
Yeah,
Next one.
for the documentation.
Yes, yes. Can.